Good evening, everybody. And it's another 30th meeting. And today we are going to go in the world of clinical pharmacy. And we have our guest, Kavi. But before he introduced himself, I'll just tell you that you can still follow us on the YouTube channel as well, but also on the Pharmacy College website. So it's pharmacycollege.pl. So please have a seat and enjoy this evening. We'll just bring the world of clinical pharmacy to your feet tonight. So thank you very much. And Kavi is our guest. He's going to talk about a very important topic, but I'm not telling you anymore. He will just tell you and pass you great information and a great knowledge. Hello, Kavi. Good evening. Actually, good morning.
Well, it's afternoon here.
So tell me about yourself.
Yeah, so I'm a clinical pharmacist, like Peter mentioned. I'm located in Ottawa, Ontario. This is the capital of Canada. So I've been working as a pediatric clinical pharmacist in CHEO, which is the Children's Hospital of Eastern Ontario. I've been there since I graduated in 2016 from University of Toronto. And so some of the areas I'm involved in now include nephrology, so hence the topic. General medicine. I'm also the pharmacist with the regional cystic fibrosis clinic, pediatric clinic. So those are some of my areas of interest.
Excellent. And you have to mention that you're also starting the project with Pharmacy Without Borders. And this is the one of the best projects actually that is running also in Poland. And we started it a few years ago. And we provided the highly rated courses in the country. So this is actually a good scope, and that's why we are here. So thank you very much to Regis Weilancourt, Dr. Regis Weilancourt from CHEO Hospital, who helped us to organize this evening, and also to our sponsors, Polish Pharmaceutical Group, SA. Thank you very much. So let's start our presentation. Today, a very interesting topic. We are going to talk about nephrotoxicity and about the drugs which potentially can actually make harm to our kidneys. So this knowledge will be very useful for the community pharmacists as well for hospitals pharmacists, and we welcome you here tonight. Thank you.
Thank you. Yeah, so like you said, I just started getting involved with Pharmacists Without Borders, so it's a really great opportunity. So I'll start my presentation. So as Peter mentioned, this is going to be a topic really focusing on drug-induced causes of nephrotoxicity. The presentation is brought to you today by PSF Canada, but also the Canadian Society of Hospital Pharmacists and also CHEO Pharmacy Department. So I'll give you a brief overview of what we'll talk about today. So we'll start by just looking at some definitions and some biomarkers of drug-induced nephrotoxicity, and then we'll talk about the epidemiology. We'll explore some risk factors, patient, drug, and kidney risk factors for nephrotoxicity. And then we'll talk about a few common implicated drugs and the mechanisms by which they cause drug-induced renal injury. And then hopefully, I know that this topic is a much more clinical topic, but hopefully I'll take it back to some practical applications and how you can apply this knowledge in your practice. So some prevention and mitigation strategies, what really is, or what are some opportunities for a pharmacist's role in this area, and then we'll also look at a quick little case. I included this quote from one of the articles that I used for this presentation, and it sort of encompasses everything that I'll talk about. So what they really say is that successful prevention of drug-induced nephrotoxicity requires knowledge of the pathogenic mechanisms of renal injury, the patient-related risk factors, drug-related risk factors, and then what are the preemptive measures that we can use. And it's also important to couple this with vigilance and early intervention. So to define drug-induced nephrotoxicity, if you look at the literature, a lot of articles refer to AKI, or acute chronic injury. And there isn't a standardized definition for drug-induced renal injury. So a lot of authors use AKI, the definition of AKI. And KDIGO, which is the international association, their 2012 guidelines dictate that AKI is a sudden impairment of kidney function occurring over hours to days. So, and they actually have definitions based on serum creatinine. So serum creatinine is the most commonly used marker of renal function. And this is generally, they consider an increase within 48 hours in serum creatinine, or at least 1.5 times increase from baseline within 7 days. So acute kidney injury is really defined within 7 days. If it persists longer than that, then you can consider chronic renal injury, which is usually after 3 months. But it's important to note that drugs can cause not just acute injury, but they can cause other disease states as well, such as chronic kidney disease, renal tubular dysfunction, and nephrotic syndrome. So you don't always see these within 7 days. You see them with longer exposure as well. And KDIGO also has some staging of AKI. So they have sort of stage 1, 2, and 3. It's not as generally used yet or in the literature, but some authors do use the staging approach. So yeah. So some biomarkers, or what are some of the ways that we can understand renal function? So like I mentioned, serum creatinine is one of the most common, but there's also blood urea nitrogen. You can look at urine output. And all these measures really help you sort of estimate GFR, which is the glomerular filtration rate. In healthy young adults, it's around 120 mils an hour. And there are certain equations that I won't really get into today, but that are standardly used to estimate GFR. So Cockcroft-Gault, you might have seen before. There's Schwartz, which is more commonly used in pediatrics. MDRD is another popular one. So I just wanted to touch base on some of the limitations of serum creatinine specifically. So one issue with serum creatinine is that it's often delayed. So increases in serum creatinine are not seen later than when renal function actually reduces. And it's also affected by other factors, non-renal factors, like when there's changes in renal vascular volume, that can affect serum creatinine, and also like age, gender, body weight, diet. So those are all reasons that can affect serum creatinine. So it's not the ideal marker, but it is the most popularly used one. And it's also the one that a lot of drug manufacturers use when they study drug dosing in renal dysfunction. So some articles discuss some new markers like IL-18, NGAL, cystatin C. The only one that I've seen in our practice is cystatin C, and that one has a benefit over serum creatinine in that it's an earlier marker of renal dysfunction, and it's also produced by all nucleated cells compared to serum creatinine, which is only really produced by muscle cells. All right, so the epidemiology of drug-induced nephrotoxicity. So commonly it's known that about 20% of community and hospital-acquired episodes are due to drugs. And it could be as high as 66% in older adults. So you can see why it's so important for us to understand drug causes of renal dysfunction. And in the critical care setting, it's one of the most important settings. So one article that looked at the incidence said that 14 to 26% of AKI is due to drugs. And when there's a combination of AKI and sepsis in the critical care setting, the mortality can be up to 80%. Now, this is AKI due to all causes, but you can see that a big chunk of AKI are due to drugs. In pediatrics, this is not just critical care, but in all pediatric hospital settings, 16% due to AKI. The other thing that's important is that incidence is probably underestimated for many reasons. Like I mentioned earlier, there isn't a very standardized definition of drug-induced kidney injury. It's really relying on AKI. And the focus is on acute injury, but you can actually see chronic injury due to drugs. The other thing is it's difficult to know if renal injury is due to drug or some sort of underlying disease states. And also community rates are not as well reported as hospital rates. So I think, and it's probably the case, that there's a lot more to be learned about the incidence of drug-induced renal injury. So now we're going to shift gears and talk about some of the risk factors. So there are kidney factors, patient factors, and drug factors that all contribute to the injury. And this is an important thing, I think, for pharmacists to understand, because it will really help us be better clinicians and help our patients. So the kidney itself is vulnerable to damage. One of the main reasons is that there's high drug delivery to the kidney, and there's high cardiac output to the kidney. So 25% of cardiac output is devoted to the kidney. The other reason is that there are high concentration of toxins that actually develop in the kidney medulla and interstitium. This is really because the kidney has a really strong ability to concentrate substances, drugs, toxins. And the other thing is that the kidney has metabolic potential. So there are actually enzymes, as you know, cytochrome 450 enzymes. We're very familiar with them being involved in hepatic metabolism, but there's actually metabolism that occurs in the kidney, and cytochrome enzymes have been identified in the kidney as well. So there could be production of toxic metabolites and metabolic intermediates that can be directly toxic to the kidneys. And we'll go over some examples later. And also the kidney is involved in secretion and reabsorption of these molecules. So when you have these processes as shown in the diagrams, some of the toxins can concentrate within the cells and cause damage. So that's another opportunity for damage. The last thing that I'd highlight is that the proximal convoluted tubule, or the tubules itself of the kidney or the nephron, they have large surface area. So there's a lot of opportunity for interaction of these molecules with the kidney tissue. And then some patient factors. So some of the non-modifiable factors include age, gender. So women are particularly, at least in the studies that I've looked at, they're more prone to renal damage than men. And also older age, some authors say 60, others say 65, but generally older age contributes. Neonates as well are at increased risk because they have changing renal perfusion early on in life, especially within the first 2 weeks of life. And they're also, their kidneys are still underdeveloped, so they're still developing. And then comorbid conditions. So patients who already have underlying renal dysfunction, so they would be at risk, additional risk of drug-induced toxicity, especially GFR under 60. Patients who are diabetics, who have heart failure, so congestive heart failure, patients who are in sepsis, other conditions such as nephrotic syndrome and cirrhosis, and these really are states where there's reduced perfusion to the kidney, and overall there's a hypovolemic state. Also, these two conditions are associated with hypoalbuminemia. So because there's less albumin, there's less binding to drug, so you have higher free drug concentrations. And then in jaundice, well, bile salts are directly toxic to the kidney, and volume depleted states, like I mentioned, because of the hypoperfusion to the kidney. And then there could also be genetic differences. So like I mentioned, there are metabolic enzymes and transporters within the kidney. So pharmacogenomics and pharmacogenetics plays a role here, where there could be interpatient variability in their risk to drug toxicity. You can also have immune responses to drugs. So between people, you can have varied responses to these nephrotoxic agents. And also there could be genetic differences in the repair pathways. So once you have damage, or ways to prevent damage is repair pathways, but there could be differences between people in that. And then metabolic disturbances. So hypokalemia, for example, enhances your toxicity risks to certain drugs like aminoglycosides. Severe hyperkalemia, which is actually, it can induce vasoconstriction, renal vasoconstriction, and leading to hypoperfusion to the kidney, and so on and so forth, like changes in pH, which can actually change the way drugs crystallize in your ureters or in your kidney tubules. And also patients who are critically ill are already at high risk for renal damage. And then drug factors. So there are several different mechanisms and several different ways that drugs can cause kidney damage. So I'll go through a few of them now. It's not an exhaustive list though. So for one thing, drugs can have different structure, charge, or solubility, and that can affect their formation of crystals. There could also be like obstructive type damage or inflammatory damage to the kidney because of that structure or solubility. So some of those examples are methotrexate and acyclovir high-dose vitamin C. And then it could also be affected by the charge of the molecules. So for example, positively charged aminoglycoside, they're actually attracted to the tubular cells. And so by that, they are able to concentrate within the cells and then cause damage that way.
Just a question. I mean,
yeah.
I'll just interrupt a question. What about trimethoprim? Because this is an antibiotic, and I remember from my practice that very often we recommended people to drink plenty of water. So if for instance, you mentioned vitamin C, I can tell you that in Poland we have a very high concentration of vitamin C, 1,000 milligrams, and for me, this is very high dose. And methotrexate, obviously, acyclovir, trimethoprim, and like, what is then the advice for the patient? Like, do you recommend to drink a lot, or maybe the vitamin C concentration is too high? What would you say?
Yeah, I think I'll go over some strategies for some of these, but specifically for the drugs that tend to crystallize, like vitamin C, I think hydration is very important, but also the dose is very important as well, right? So just looking at, you can obviously get counseling from your pharmacist on the appropriate dose to use and what doses would be considered toxic. Yeah, for sure. So I think hydration is probably one of the main things you can implement. Yeah.
Super. Thank you. I'll just interrupt time to time to just make more dynamic that we just sort of here. Yeah. Thank you.
That's good.
Awesome.
That's great. So yeah, so we were talking about the structure, but also the other thing is the dose and the duration of exposure. So higher doses or prolonged exposures will enhance kidney injury. So even in patients who have like minimal or no underlying risk, and combining drugs obviously is a risk factor, especially combining drugs who have synergistic effects, and we'll actually look at a specific example of this later. And drug-drug interactions, and I talked about inflammatory potential already. So specifically with the inflammatory potential, what could happen is these drugs can lead to production of reactive metabolites and reactive oxygen species. And we'll go over this specifically when we talk about interstitial nephritis. Okay, so some of the common pathogenic mechanisms. So I've broken them down into 3 broad categories, but there are more, and many drugs are associated with nephrotoxicity, and there's more and more being discovered now. So the 3 main that I'll talk about is pre-renal, which is basically what's happening is there's altered perfusion to the kidney, and that changes the pressure in the glomerulus, which is really important to maintain renal function and urine output. And then there's intrarenal or parenchymal. This is when there's damage directly to the tissues of the kidney. There's a few different types that I'll go over. And there's also post-renal, which is, or obstructive, and crystal nephropathy is one of the most common ones. And we'll go over acyclovir and how it causes that later. Okay, so pre-renal toxicity. So these drugs, the main mechanism is that they cause some sort of changes in the perfusion to the kidney, and the kidney has compensatory mechanisms to try to maintain renal blood flow and urine output, and hence GFR. So what these drugs will essentially do is they'll cause ischemic damage to the renal, to the nephron, and patients who are at risk. So if a patient already has some sort of condition that reduces their renal blood flow, like renal artery stenosis, or they have reduced circulatory volume, like in cirrhosis or nephrotic syndrome or CHF, they would be at additional risk. But with this type of renal injury, it's often reversible, and it's often fairly rapidly reversible in the first 24 to 48 hours after correcting the hypoperfused state. So some examples: NSAIDs, this is their main mechanism of causing renal injury, cyclosporin, ACE inhibitors, and ARBs. So let's look at one example. So NSAIDs, like I mentioned, they cause some sort of reduced perfusion to the kidney, and that leads to ischemic damage. So you can see in this diagram, the diagram A shows you normal renal perfusion, and then NSAIDs, essentially what they do is they cause constriction of the afferent arteriole. This is the arteriole that brings blood to the glomerulus. The one that leaves from the glomerulus is the efferent. So essentially what they do is they can cause AKI, they can cause nephrotic syndrome, hypertension, hyperkalemia, and other states. The incidence is about 15% is what it's estimated in hospitalized patients. And as you know, NSAIDs inhibit the production of prostaglandins, and prostaglandins play an important role in maintaining that vascular tone in the afferent arteriole. So by inhibiting it, the kidney is not able to dilate that afferent arteriole and bring enough blood to the kidney, and hence you have reduced renal function. It's also important to note that there is also reduced renal excretion of sodium. I think that's a mistake there, I'll fix it later. And so that also contributes to hypertension. COX-2 inhibitors, selective inhibitors like celecoxib, they're not safer, and that's because COX-2 enzyme is also involved in production of prostaglandin. So what are some of the risk factors specific to this? So patients who have already impaired renal dysfunction, any of these pre-renal mechanisms, the hypovolemic states are an increased risk factor. And then patients who have CHF, older age, use of ACE inhibitor because of a synergistic mechanism, which I'll discuss. And if patients already have some sort of vascular disease, renal vascular disease. So generally, it's recommended to avoid NSAIDs in patients who have end-stage renal disease or who have stage 4 or 5 CKD. And like I mentioned, usually once you stop the agent, the renal function usually reverses, in most cases at least. So I wanted to show you guys this. This is actually a little screenshot from our electronic medical system. This is a patient who has end-stage renal disease, patient who's on dialysis, and we actually have NSAIDs added as an allergy or contraindication in their chart. And this flags anytime a prescriber puts through or orders a related medication like an NSAID or ASA, this will actually flag the prescriber. So it would be an early step catch to avoid such renal damage in a patient like this. Okay. And now we'll talk about ACE inhibitors and ARBs. It's a similar mechanism, but they actually act in the efferent arteriole, like shown in the diagram. So essentially what they do is they inhibit, or they lead to loss of efferent arterial tone. So usually angiotensin 2, it acts in this part of the kidney to actually cause vasoconstriction. And by constricting there, you can maintain the pressure in the glomerulus. So by inhibiting the molecule that acts here, you're actually going to reduce the pressure in the glomerulus and therefore renal dysfunction. I guess I didn't put in the incidence. Sorry, let me go back. All right, so risk factors. So patients who have renal artery stenosis, if they have atherosclerotic disease, again, hypovolemia, diuretics or NSAID use, diuretics specifically because they can cause a hypovolemic state, and CHF. So in general, what prescribers can do is they can actually start patients at a lower dose and then titrate up based on response. And then mild increase in serum creatinine are acceptable. But again, we check the baseline and then check shortly after starting. One thing to note with ACE inhibitors and ARBs is that they can actually be beneficial in that they can slow the progression of renal injury. So we actually use them in patients to slow renal injury, but it can also cause renal injury. So it's really a double-edged sword. So it's always a question of weighing your benefits and risks.
Just a question. Because ACE inhibitors are also recommended for type 2 diabetic patients. This is like one of the standards, isn't it? And this is just to protect the kidneys. Am I right?
Yeah, so the mortality benefit that is the reason it's used is for mortality benefit. And it's been shown that it can affect tissue remodeling, and also it can slow the progress of renal disease in those high-risk patients. But at the same time, it can cause, acute kidney injury. So you really have to weigh your risk and benefits.
But do they cause the kidney injury only when they act as a single? I mean, as themselves,
It's
but
rare. Yeah, like that's why the risk, like your risk is increased when you're using additional nephrotoxic agents. So it's a lot less common when it's just by itself. Yeah.
So from one side, doctors are prescribing ACE inhibitors for type 2 diabetic patients, but from the other side, we have a risk to get a kidney injury as well if we abuse, for instance, NSAIDs like ibuprofen, aspirin, and this is very and common problem, definitely.
Yeah, it's pretty common. I think that's why it's so important to monitor, right? So you might want to start it, and it's common that you use it in a patient who's on an ACE inhibitor and a diuretic like furosemide, when that increases your need to monitor those things, right?
Mm-hmm. Super.
Okay, so generally in patients who have renal injury due to these drugs, they're often not symptomatic. Their urine output may not change much. They may have hyperkalemia, so it's difficult to detect, and it usually takes a few days. So that's why it's important to check your serum creatinine or check your renal function in a couple days or a week or two after starting treatment. And another one that causes similar type of renal injury or through similar mechanisms are calcineurin inhibitors. So cyclosporin, tacrolimus, those are common drugs in that category. And they can cause actually chronic renal dysfunction as well. Similarly, they cause vasoconstriction of the arterioles bringing blood to the kidney. Again, they're also reversible. And they're reversible if you either DC the drug or you can even dose reduce and get some reversal of renal injury. Generally, with these two drugs, we monitor renal function, but we also check serum levels so that we can use the lowest effective dose, so we can see that it's dose-dependent side effect. And it's also important to manage the interaction, so you can have a lot of interactions with these drugs that can increase your drug levels, so it's important to identify those and manage those accordingly. And then here we have some examples of intrinsic renal injury. So the mechanism here is that there's direct damage to the tubular cells. So the drugs are exposed to like active secretion and reabsorption in the tubular cells. So for example, with aminoglycosides, they tend to concentrate in the tubular cells. So there's a few different types here. There's acute tubular necrosis, which is direct damage to the tubules. There's also interstitial nephritis, which is more of a immune-mediated mechanism. You can have thrombotic microangiopathy. And there's also other mechanisms that lead to this intrinsic renal damage, but I'll focus on the first two for today. In general, with this type of mechanism, because there's damage to the cells, direct damage to the cells, you actually see if you do urine analysis, you can see granular casts, you can see red blood cells and white blood cells being actually excreted into the urine, which is not normal. And they're usually in the form of white blood cell and red blood cell casts. So let's look at an example. So we have aminoglycosides, fairly commonly used in the hospital. So the mechanism is that, for one, aminoglycosides are positively charged and they're attracted to the negatively charged phospholipid membrane. And they're actively taken up into the cell through lysosomes, and they cause direct damage to the lysosomal enzymes and the mitochondria. And they also accumulate within tubular cells. So this really results in acute tubular necrosis. So some of the things that you see is that you see the granular casts in your urine. The serum creatinine doesn't rise typically right away, but in some patients who already have underlying disease, it can rise more quickly. And incidence is reported about 10 to 20%. So what are the risk factors? The dose and exposure is probably the most important risk factor. So it's really depending on how much you expose the kidney to this drug. Repeated courses, high trough concentration. So this is when you check your levels of aminoglycoside. If you have trough levels above 2 for prolonged periods, that increases your risk. And also, if you have patients with electrolyte abnormalities like potassium and magnesium, they would also be at risk for this type of damage. So what are some ways to manage this? Discontinuing would reverse the damage. Fluid and electrolyte balance is really important. So making sure that your patient's maintaining their urine output. Ideally, you should avoid other nephrotoxic agents when you're using an aminoglycoside. So prevention is really the key. And some strategies for prevention: extended interval versus conventional dosing. So conventionally, we used to dose aminoglycosides every 8 hours, at least tobramycin and amikacin is dosed that way. And some studies have shown that giving extended intervals, so Q24, that actually reduces your risk of renal damage. So the plausible mechanism, it could be that by giving a dose once a day every 24 hours, you actually reduce the risk of accumulation within the cells, because this is really an active transport mechanism. And so by overwhelming these active transport mechanisms, you can reduce the reabsorption of aminoglycosides into the cells. Obviously, doing TDM and monitoring your trough levels is important. We mentioned hydration, making sure that patient maintains a renal function, and also limiting therapy. So typically it's recommended, or we know that damage is increased when you use it for longer than 10 to 14 days. So we try to limit that in the hospital setting. Another drug that causes intrinsic renal damage is amphotericin B. So the amphotericin B mechanism is really direct tubular toxicity. So some of the findings, it is often associated with magnesium and potassium and other electrolyte wasting, and it's also associated with renal tubular acidosis. There's actually a really high incidence, but this is really with the older formulation of amphotericin, and it's associated with high or cumulative doses. So again, it's exposure related. So some management strategies, we can use the liposomal formulation. So it's called AmBisome, and it actually targets the drug to the fungal cells rather than the human cells. Other strategies that we use in patients who are already at high risk for nephrotoxicity or who have underlying disease, we might administer sodium loading prior to the doses. We obviously manage the electrolytes very closely, because most of the time these patients, their potassium and magnesium start to drop very quickly, and it's generally reversible when you stop the drug. High dose and volume depletion are some of the risk factors. A few more drugs that are in this category: statins, for example, they also cause direct toxicity to the renal tubular cells. What they essentially do is they can cause rhabdomyolysis, which is injury to muscle cells, and then those injured cells, they release myoglobin and CK and other content, and those myoglobin and CK are actually directly toxic to the kidneys, and they can actually cause changes in GFR and tubular obstruction. And then a few other drugs: vancomycin, radiocontrast agents, so the stuff that you use when you get your CT scans with contrast, and cisplatin also causes injury through the same mechanism. Okay, so that was a few tubular toxicity mechanisms, and then there's also acute interstitial nephritis, which I mentioned earlier. The mechanism is a little bit different. This is an immune-mediated reaction. It's idiosyncratic. So basically, this means that it's not dose-dependent. So just by reducing the dose, you cannot overcome this type of toxicity. And there are drugs that really they're either antigens or they act by binding to other antigens, and they deposit into the interstitium of the kidney. So you often find patients complain of hypersensitivity reactions, for example, fever, rash, joint pain. They often show proteins and red blood cells in their urine, and you can also see white blood cells because of this inflammatory state. You'll see white blood cells in the urine. So a few drugs that cause this: allopurinol, beta-lactams like methicillin was known to cause this. Acyclovir can cause AIN. Diuretics like loop and thiazide diuretics, NSAIDs. So as you can see, NSAIDs cause nephrotoxicity in more than one mechanism. PPIs, so like pantoprazole, lansoprazole, rifampin, and also some herbs can cause this this type of toxicity. So I don't have any specific examples, but generally Chinese herbs can cause this. And then to manage this, you really have to stop the therapy. So it's reversible in most cases. It takes a little bit longer to recover from this, and it takes maybe a week or so. In some cases, you have to start steroids. The evidence for this is controversial, but sometimes it's recommended. And in some cases, you might even need to use immunosuppressive therapies. Okay. Any questions, Peter, before I move on to this last one?
Well, I was quite interested in the Chinese herbs. I mean, in Poland, it's quite popular because we're using lots of herbal products, and people think that it's natural, and they don't even know how much damage they can cause, basically. So this is not really safe, and although it's natural, basically, it still can interact with medicines that the doctor prescribed, and it can actually cause more damage than good.
Yes, because we don't know as much about them as other stuff. We don't know what's in these preparations. You don't know the doses. There could be traces of other ingredients. There could be differences between every single bottle of these herbs. So yeah, for sure. I think that's why it's so important to understand what your patient is taking, the history, and taking a thorough history. So we'll chat about that later.
Yeah.
Okay, so the last category that I'll talk about today is post-renal, and this is an obstruction of the urine outflow. So it can be an obstruction within the tubules or within the ureters. And basically, what happens is that there's insoluble crystallization in urine. So some of the drugs that are commonly associated with this, acyclovir is a very common one, probably the most common in this case. Some of the antiretrovirals like indinavir, methotrexate, vitamin C, like we mentioned, but at large doses, they can cause oxalate crystals in the kidneys. Ciprofloxacin, oral sodium phos is a solution we use for like bowel prep before certain bowel procedures. So who is at risk for this type of renal injury? So again, severe volume depletion, because you can actually increase the concentration of these agents in the tubules, and so they have higher risk of crystallizing. Metabolic disorders, so certain crystallization, by changing the pH, you can actually cause them to crystallize. They're more likely to crystallize in certain pH, especially, for example, indinavir and cipro. They crystallize more likely at higher pH, whereas lower pH, under 5.5, you can have, you increase your risk of methotrexate crystallization. And other risk factors, so the pH in the urine is another important thing. Acetazolamide and topiramate, they actually inhibit, they induce formation of alkaline in urine because they inhibit carbonic anhydrase. And so by doing that, they can actually increase your calcium phosphate precipitation in the tubules, and you can have more kidney stones. And then HIV patients, which I thought this was interesting, but this article from New England, they talk about this case here of a 60-year-old patient, HIV positive, treated with IV acyclovir. And this patient's serum creatinine doubled after therapy, and it actually returned to baseline after stopping and giving fluids. And if you look at the microscopic slide of their urine, it actually looks like this. And these are the acyclovir crystals that form in the urine. And with acyclovir at higher doses, you're more likely to have this. And in some cases, giving a drug IV, it is associated with higher risk.
Question from Daniel. I've got a question about the gentamicin and flu level. Level 2 micrograms per milliliter applies to dosage 2 times daily. And the question is, admitting once daily should be generally safer.
Yeah, I think with all aminoglycosides, giving it, so it's really called extended interval dosing. I don't know specifically for gentamicin, but like, I think is the question. So giving it once a day should reduce your risk because what's happening is, like I mentioned in the mechanism, let me go back to my slide. Good question. So what happens is that aminoglycosides, this is the part of your tubule where there's urine formation, and this is your side with the blood. And aminoglycosides are attracted to the cell membrane and actively taken up into the cell where they cause damage. So by giving a larger dose of aminoglycoside once a day, because when you're doing it every 8 hours, you're giving a lower dose every 8 hours, or you're giving it every 24 hours, but you're giving that total daily dose within that 24-hour period, you can saturate these active transport mechanisms. And so it's less likely to be taken up into the cell, and so less likely to cause damage. I don't know if that answers the question.
So to summarize, basically, you should administer it twice a day, but with a smaller dose instead of once daily, higher dose. So twice a day, smaller dose is safer.
That's what studies have shown, and I think the authors say that this is the most likely mechanism that it does that. Yeah,
that makes sense.
Okay, so post-renal obstructive damage. If you look at the urine, if you do a urine analysis, oftentimes there are red blood cells and white blood cells, but also crystals, like I showed in the urine analysis. So to manage this, stopping the offending agent is probably the most appropriate, but also hydration, like we talked about with the herbs and the vitamin C. In some cases, adjusting the pH can also be helpful. So in terms of the hydration, when we give acyclovir IV, we actually recommend giving high dose fluids before and after every dose. So we actually give 1.5 times maintenance doses, which is high dose of fluids for an hour before and after giving the acyclovir, and that actually reduces your risk. Okay, so those are some of the examples. Obviously not an exhaustive list, but I want to switch gear now and talk a little bit more practice related and how we can use this knowledge to improve outcomes in our patients. So what are some roles pharmacists can play to reduce the risk of drug-induced kidney damage? So this is actually a diagram that Jamie talked about in her last presentation, and it's a very common process that we use, or that we're taught in school at least. It's called the pharmaceutical care process. So it's really a systematic and standardized approach to collecting information and then assessing the treatments, and then putting together a plan and implementing it, and then having a follow-up plan on how to move forward with your plan that you've implemented. So, the key thing, I think, is that as a pharmacist, when it comes to preventing and managing, but really preventing, it should be the goal of therapy. And when it comes to drug-induced damage, is to have a thorough history. So if without a thorough history, without knowing our patient, we can't really identify all those risk factors that we talked about, so patient risk factors, the drug risk factors. So it's really important to have that history, and then to document that history. So to maintain a patient profile of, what medications has this patient taken, what are they taking now, what medical conditions do they have, and then communicating based on that. Then you can assess the patient information that you collected, and you can come up with a plan, and then you should communicate that to the clinical team, right? And then you should document all that information, your communication, your plan, and what kind of follow-up do you plan on doing? Do you want to check levels in a week? Do you want to check levels in a week? What kind of levels do you want to check? And at the end of the day, the pharmaceutical care process it's a joint decision-making process between the healthcare provider and the patient, and the healthcare providers includes you, the pharmacists, physicians, and anyone else involved.
Kavi, we have a question. Despite meeting one of the acute kidney injury criteria, according to KIDGO, I just can't pronounce it here. In your daily practice, please tell me, how do you determine type of AKI, pre-intra, post-renal, and additionally drug contribution to AKI, despite the other factors like dehydration or other coexisting diseases influencing GFR?
So determining the type of AKI, I think, I think it depends on the drugs that they're taking. So you can, like I said, assessing the risks. So you're assessing the risk based on patient underlying risk factors. And then you're also assessing the risk based on the different drugs that they're taking and the mechanisms by which they cause AKI. You can sort of think about what type of AKI it can cause. So if a patient's on a lot of drugs that cause pre-renal AKI and then you're adding an NSAID, then you know that most likely that's the mechanism. But when it comes to clinical management, in practice, you don't worry so much about the type of damage that is happening. What you worry about is, doing the basics like the fluids, reducing the number of nephrotoxic agents that they're taking, correcting any underlying risk factors like volume depletion, reducing the dose, for example. And I'm just reading the second part of the question additionally. Yeah, I think as a clinician, if you don't have that information based on like the urinalysis, you don't have the creatinine information, and you're really going based off of the patient history and the medication history.
Mm-hmm. Cool. Let's carry on with the presentation.
Carrying on. So, and other roles that a pharmacist can play, I think as a pharmacist, it's really important to educate and empower your patients. So making sure that they have good knowledge of their own conditions, educating them on the medication regimen. So one of the ways that we do that is through medication reviews, and also counseling them on steps they can take to avoid some of the renal toxicity that we talked about, like making sure they're hydrated. And by doing this, by educating and empowering your patient, you can actually impact their adherence to therapy, right? So those are some of the roles we can play. Another important thing that we can use is electronic medical records. So these are important tools for us to keep a history of our patient, but they can also help you identify when there are patients who have additional risk factors. So these decision support tools, these electronic support tools, and things that can identify drug interactions. So I think that can play an important role in our practice. So I just want to show you as an example. This is an example from our electronic medical record at CHIO. And at CHIO, like, for example, some of the labs that we can see, like the electrolytes, we can actually see our system is also able to calculate EGFR estimates based on the different parameters that those estimates need. So we can see like their EGFR, we can see their cystatin C measurements. We can also see like urine chemistry. So we can see, does this patient have proteins? Does this patient have white blood cells in their kidney? Do they have blood in their kidney? Those can also help us identify kidney damage. And it can also like compare, for the last question that we got, it can help us give an idea of what type of damage they had. And the other cool thing at CHIO is that for most of our patients, if the parameters that are needed to calculate an EGFR are there, it would actually show up at the top of the chart, which I think was neat. I don't know what you think, Piotr, but that's very useful because I can see this, right at the top of the chart, and it helps me, know if I need to adjust the dose of a drug that I'm prescribing, for example.
For me, it was during my training in CHIO.
Mm-hmm.
I was shown all these amazing things, basically, that they don't exist in Poland, and especially pharmacies that don't have access to it. So definitely, I found it extremely useful. Also, including this special software system with algorithms to support basically sort of being able to justify whether the interaction is clinically critical or not. So this was also quite good. And this also the evidence that the hospital provided, that was also interesting, and the databases. This is something that basically at the moment Polish hospitals do not provide, and obviously I'm missing that. So it was great time for myself regarding my education, especially clinical skills. And I think we have another question as well, Kavi.
Oh, yeah.
Drug-induced kidneys damage is stronger in COVID patients. I would say that mainly COVID is related to the lungs problems rather than kidneys, but obviously.
But there actually have been reports, and I'm sorry to say, but I'm not up to speed with all the COVID literature, but there actually have been reports of kidney damage specifically in COVID, not so much due to drugs though. So that COVID-related kidney injury could be a risk factor, for example, for a patient to get drug-induced nephrotoxicity, right?
Yep.
Yeah.
But we definitely have to screen for the cardiological events and problems with heart. So this is something that I think is recommended after going through the infection.
Mm-hmm.
So if you think you recovered, you should monitor yourself for a long while.
Yeah, yeah. The other thing I wanted to show is, so this is actually a standardized form that we actually use in community practice here, and it's called the pharmaceutical opinion. It was actually implemented some time ago, and it's a standardized tool to take a history and then identify or assess what kind of issues you've identified for this patient's pharmacotherapy, and then you can actually communicate through this form to the prescriber, and then the prescriber can communicate back to the pharmacist through this form, and this is actually used in community practice. So I thought I'd share that with you guys.
It's a good concept, and I think it was also introduced in France a few years ago. I think before Canada.
Really?
I'm not sure how, when did you introduce this concept?
This was actually before I graduated, but
okay.
yeah, it's been at least 5 years.
Yeah, same time. I think the same time.
The other interesting thing is when you do fill out this form, pharmacists are actually remunerated for this. So there's actually some fees associated with this type of action, and they've actually expanded on this, where they've given pharmacists the ability to adapt prescriptions and change certain doses, and they can then use a different form to communicate that to the prescriber.
Well, very interesting service.
Yeah. So, so some of the keys to management is some sort of clinical pearls. So the key really is to prevent and mitigate severity. So the prevention always comes first. So you want to identify your risk factors and then find ways that you can prevent the renal damage in the first place. You want to detect renal damage early. So when we talked about those biomarkers and markers of renal damage, you want to use those to your advantage. You want to identify your risk factors. So you want to get to know your patient, you want to know what kind of risk factors they have, and then weigh your benefits and risks. And then recognizing the drug potential, the nephrotoxic potential of each drug. We talked about hydration. Minimizing the number of nephrotoxic agents is very important. And then if you can switch to a drug or an agent that does not have nephrotoxic potential, that would be ideal. In some cases, if it's dose related, you should use the lowest effective dose and use it for the shortest possible duration. You should use TDM whenever possible, so therapeutic drug monitoring, monitoring renal function. And then if you have a patient with underlying renal dysfunction, then you want to use renal adjusted dosing. So those are just some of the keys of management. Shall we move on to a case?
Definitely. This is the most interesting part, and I'm sure that everybody was looking forward to it.
All right. So this is Patty. So Patty's a 7-year-old woman. She presents to your pharmacy today with a prescription for naproxen 500 milligrams twice a day. She's been having new onset hip pain, likely secondary to osteoarthritis. You've never met Patty before, nor do you have any history on file for her. So what is the most appropriate first step? A, fill the prescription and counsel her on appropriate use. Ask Patty if she would have a few minutes to discuss her health history, or suggest acetaminophen instead. I'll wait a few minutes. So
you give everybody a minute just to think about it.
Yeah.
Anybody?
Feel free to.
Feel free, exactly. Don't worry, we don't bite. Express yourself. Few seconds delay, okay.
There we go.
B, Małgosia.
Okay, well, I'll move on. But yes, you're right, B. And so this really highlights why it's so important to sit down with your patient and take history. So if you remember CHAMPS, Piotr, you should be an expert at this now.
Well, so many times already.
Yeah, you've probably seen this enough. So
yeah, it's awesome.
yeah, so CHAMPS is an acronym that we use to sort of standardize. It's a standardized approach to collecting, your medication and your medical history, but it also has other things like social history, functional history. So you asked Patty to talk to you. So this is the rest of the case. She reveals that she has stage 3 CKD, hypertension, and chronic congestive heart failure. Other history that you can take, so medical history like surgery or hospital admissions, if they're a tobacco or alcohol user, if they have assistance at home with daily living. She reveals that she has pain that is interfering with her daily activities, so this hip pain that she's having now. She's needing increased assistance at home. In terms of allergies, she does not have any allergies. Medication, so she's on metoprolol 25 milligrams twice a day, ASA 81 milligrams once daily, or aspirin, lisinopril 20 daily, furosemide 40 twice a day. And in terms of her signs and symptoms, so she has new onset hip pain, like she mentioned, most likely osteoarthritis related. She says that it's worse in the evening, and through your access to medical charts, you notice that her baseline serum creatinine is 156. She has normal electrolytes and normal urine analysis. So the next question is, which of the following are Patty's risk factors for acute kidney injury?
So we give them like a few minutes.
Oh, we have a few answers before.
Yeah, it's B. So everybody was correct. We are happy to hear that. What's the CKD stands for?
Oh, sorry. Chronic kidney disease.
Okay.
We have one.
And it's very interesting here.
B.
Okay.
Well, I'll move on because I think we're short on time now.
I would go for E as well.
Pardon me?
I would go for E as well.
You go for E. All right. You got it right. So yeah, so age, older age, gender, like we talked about. She already has underlying renal dysfunction, congestive heart failure. It, like I said, it's associated with hypovolemic states. And then she's also on other nephrotoxic drugs like furosemide and lisinopril. And this is a bonus question. So Patty returns in 5 days. She has edema. Her blood pressure is elevated. Her labs, which you're able to check now, after 5 days, her serum creatinine increased by 55%. Her potassium is up to 6.9, but her urine analysis is still normal. So which of the following is the most likely complication of naproxen use in this patient?
We'll give them a few more seconds. This is the difficult one. More complicated. There's a bonus. Jonas is C.
Okay, we have one answer. We have another C. We have some smart viewers.
Yeah, definitely.
Okay, so I'll explain why C.
Absolutely.
So this case illustrates something referred to as a triple whammy, which Peter is the one who made me aware of this, but it's actually defined in the literature. So if you look at the 3 drugs that this patient is on now, you have prostaglandins. So in patients who have volume depletion, so this patient has risk factors for volume depletion. She has CHF. She's on furosemide. Renal perfusion really depends on prostaglandins to vasodilate the afferent arterioles so they can maintain that blood flow to the kidney. So, and then angiotensin 2, which is a vasoconstrictor, it also acts in the same way, and it maintains the pressure in the glomerulus. So this patient is on diuretics, which already exacerbates volume depleted state. It can also cause AIN, but and then NSAIDs, they inhibit the prostaglandin mechanism, and then you have ACE inhibitors which inhibit the angiotensin mechanism. So you have sort of a three-pronged synergistic mechanism that all add up to renal dysfunction in this patient. So that's why I guess that's why it's called the triple whammy.
Exactly. So three different hits on the kidneys.
Exactly. And that's it. So I just wanted to thank a few people. So Regis, who's our director of pharmacy at CHIO, he's also the PSF Canada Poland lead. Peter, obviously, and everyone who attended today for putting together this talk, and everyone who took the time to come and listen today, PSF Canada, and obviously CSHP.
Kavi, so it was a great time for everybody. So if you have a chance, put the thumbs up, please, for that. And if you despair for more, we'll just carry on with these workshops, and we invite more guests. So I think in 2 weeks' time we talk about medical marijuana. It's a very interesting topic, and we have some experts. And then we have an extremely brand new, fresh topic about pharmacogenomics. So we just try to basically show you how the genes can influence the drug metabolism and what we can do. So this is really super new. And today we thank you, Kavi, for this. This was so excellent. I really had a really good time. So thank you very much. And it was brilliant, really great explanation of the acute kidney injury. And I think everybody knows now that the role of pharmacist is just it's unbelievable. The world needs pharmacists. Let's put it this way. So thank you very much for this, and thank you for being with us. I know it's late, but hopefully you enjoy it. And thank you very much for the good comments. We really appreciate it.
Yeah, thanks everyone. Thanks for coming, and thanks for having me.
Thank you very much. By the way, just to finish off, there's snowing in Canada, so we are lucky people. Thank you very much. So good night, and see you soon in a week. Thank you, Kavi.
Thank you.
Szanowni Państwo, drogie koleżanki i koledzy farmaceuci. Mam na imię Piotr Merks, jestem kierownikiem kursu Prescribing farmaceutyczny Pro Familie Pro Autore. Szanowni Państwo, czas pandemii to czas, w którym nasza profesja szczególnie zyskuje. Jednym z takich przywilei było właśnie uzyskanie możliwości przepisywania recept Pro Familie Pro Autore. Jednakże proces przepisywania jest procesem bardzo wymagającym, ale również wymagającym dużej wiedzy. Z uwagi na to, że nikt wcześniej nie przygotował tego typu szkolenia, abyście Państwo w sposób pewny, bezpieczny przepisywali leki dla swoich rodzin, ale również dla siebie, postanowiliśmy wyjść naprzeciw tej potrzebie i w ramach Polskiej Grupy Farmaceutycznej Działu Innowacji i Badań Naukowych wspólnie ze swoim zespołem przygotowaliśmy dla Państwa ten kurs. Kurs jest wyjątkowy po pierwsze z uwagi na to, jakich gości zaprosiliśmy do współpracy. Są to lekarze, farmaceuci kliniczni, ale również eksperci. Że tak powiem, osób, które bardzo nam tutaj pomagały. Jednym z bardzo ważnych elementów tego kursu jest to, że możecie zdobyć aż 67 punktów edukacyjnych. Jest to wyjątkowy kurs, wymagający pracy podczas weekendów. Są to 3 spotkania weekendowe, do których Państwa serdecznie zapraszamy. Na pewno ilość wiedzy, którą Państwo zdobędziecie, jest wyjątkowa oraz wyjątkowo przydatna w Waszej codziennej praktyce. Jednocześnie chciałbym serdecznie podziękować wszystkim wykładowcom oraz całemu zespołowi Polskiej Grupy Farmaceutycznej, tutaj Działu Innowacji i Rozwoju za merytoryczny wkład, ale również za ciężką pracę w przygotowanie tego kursu. Dziękuję Państwu serdecznie, zapraszamy.